Hey everybody, Dr. Rapich here from Vet Triage. I am in yet another hotel lobby. This is in Long Beach, California, getting ready for a Fetch conference with DVM 360. So we are continuing through this issue of JAVMA here, February 15, 2017 issue, and we're talking about the Theriogenology question of the month. This is a 2.5-year-old, 680 kilogram or 1,496 pound Hereford bull. The bull had a large scrotum. He was used as a herd sire, has been housed in a pasture with cows for 2 months. Large scrotum over the past 3 days. The referring veterinarian aspirated the swelling over the scrotum and found that there was a fluctuant area that contained dark brown fluid. Palpation of the scrotum revealed that the left testes did not move freely within the scrotum and that the testes were soft and less turgid. There was signs of discomfort when they were palpating the neck of the scrotum over this area. The right testes was freely removable within the scrotum, but also was less turgid than normal. Ultrasound showed multiple circular and tubular structures with peristaltic movement. Transrectal palpation revealed several loops of bowel entering the large left inguinal ring. Inguinal herniation of the small bowel was suspected. This is a picture. I don't know what a normal bull's scrotum looks like, but there you go. There's the enlarged scrotum there. And they diagnosed inguinal hernia. Inguinal hernia in bulls can occur as a result of abdominal viscera passing through the inguinal ring, where the viscera enters a vaginal cavity between the parietal and visceral vaginal tunics. That's called an indirect inguinal hernia. If it occurs by traumatic rupture of the abdominal musculature adjacent to the inguinal ring, then you get visceral herniation external to the vaginal tunics, and that's called a direct hernia. Anesthesia was performed, a 20-centimeter incision made over the skin, over the left inguinal ring. The parietal vaginal tunic was incised to open the vaginal cavity, which contained approximately 2 meters of herniated jejunum and some omentum. Intestines appeared healthy. Adhesions were disrupted because the extensive fibrous adhesions between the parietal and common vaginal tunics of the left testes. They're worried that this would disrupt scrotal thermoregulation. Therefore, a left unilateral castration was performed before closing the inguinal ring. The bull recovered. They gave him penicillin G procaine. He had some postoperative ileus a day after surgery, which resolved with lidocaine. And this is a picture of in surgery. And you can see there a whole bunch of intestines coming through the inguinal ring there. So, pretty wild. Discussion. A direct hernia occurs as a result of a defect in the abdominal musculature. When abdominal contents pass through the inguinal ring without disruption of the parietal vaginal tunic, the herniated contents are contained within the space between parietal and vaginal tunics. Indirect inguinal hernias cause strangulation of viscera contained within the hernia, but less likely than direct inguinal hernias. In cases of indirect inguinal herniation, the scrotum has a hourglass shape because the vaginal cavity in bulls is narrower, immediately proximal to the dorsal pole of the testes, which restricts herniated viscera to the scrotal neck and prevents migration into the distal portion of the scrotum. For both types of inguinal hernias, testicular thermoregulation is compromised and potentially can affect the contralateral testes, interrupting spermatogenesis. Indirect inguinal herniation reportedly occurs more commonly through the left inguinal ring. This has been postulated to be attributed to the tendency of the bulls to lie in right sternal recumbency, where the rumen pushes more weight onto the left side of the body than the right, and abduction of the left hind limb opens the left inguinal ring. Indirect inguinal herniation is most commonly seen in bulls that were overconditioned as yearlings. This may occur because overconditioned young bulls deposit excess retroperitoneal fat in the area of the scrotal neck, which potentially enlarges the inguinal rings. When the excess weight is lost, a larger inguinal ring may allow viscera to pass. And they didn't mention in this paper what the dark fluid the referring veterinarian aspirated. I imagine he probably aspirated intestinal contents, but they didn't mention that here. Omentum jejunum or jejunum ileum is most commonly herniated. If the condition is long-standing, the testes on the affected side will degenerate. Secondary to disruption of thermoregulation, the affected testes may be smaller, and echogenicity of the affected testes will be increased. Biting or jumping over a fence or a tear in the vaginal tunic is referred to as a direct hernia. There's a greater chance of strangulation of the intestines with a direct hernia. There is no predilection for the side of the body associated with those hernias. Few bulls with a direct hernia survive more than 4 to 6 days after injury because adhesions prevent manual reduction of the herniated intestine, and vascular compromise following strangulation is common. Surgical repair via an inguinal approach in the anesthetized patient is the only treatment option. Intestinal compromise requiring resection anastomosis may occur following both direct or indirect herniation. Surgical repair of an indirect inguinal hernia may be accomplished through a flank incision for a bull in standing position or through an inguinal incision for a bull position in lateral recumbency. The standing flank approach has the advantage of not requiring general anesthesia, but disadvantageous that the surgeons are restricted in their ability to break down adhesions or achieve anatomic alignment when reconstructing in a large inguinal ring. Through the inguinal approach, although the inguinal approach requires general anesthesia, it provides opportunity for visual inspection of herniated contents and is preferred when there's a likelihood of adhesion formation. Unilateral castration may be necessary if there is irreparable damage or extensive adhesions, which will impede testicular thermoregulation. The testicular parenchyma must be maintained at 4 degrees to 7 degrees Celsius below core body temperature for normal spermatogenesis. Intricate relationships between the arterial and venous vasculature allow heat from arterial blood supplying the testes to be transferred to the venous vasculature before the blood reaches the testes. This counters current heat exchange mechanism, coupled with the actions of the tunica, dartos, and cremaster muscles, is essential to maintain thermoregulation. Intrascrotal adhesions can prevent mobility of the testes within the vaginal cavity, which limits the ability of the tunica, dartos, and cremaster to effectively raise or lower the testes within the vaginal tunics in response to thermoregulatory cues from the scrotal sensory nerves. The pampiniform plexus plays a vital role in thermoregulation. Inflammation that generates excessive heat or adhesions that interferes with testicular mobility in response to contractions of the tunica, dartos, and cremaster muscle will impede thermoregulation and result in disruption of spermatogenesis. Excess heat from the affected testes may potentially be transferred to the contralateral testes, which would result in disruption of thermoregulation in both testes. If the condition is not corrected, damage to the other testes caused by loss of thermoregulation may be irreversible. If the testes remaining after unilateral castration is healthy, it will hypertrophy and may be capable of up to 75% of the original spermatozoa producing capacity of the paired testes. After adequate recuperation time, which is about 60 days or more, this allows for complete spermatogenic cycle following resolution of thermoregulation disruption. The remaining testes can then produce a sufficient number of morphologically normal, progressively motile sperm that impregnate cows. However, such bulls cannot be classified as satisfactory potential breeders for the Society of Theriogenology breeding soundness exam because of the fact that they have one testes. Prognosis is guarded for those that have strangulated viscera, and these patients require more medications after surgery, but there is a chance also of recurrence with either herniation. That's it. It's a nice quick one, pretty straightforward case study there, and yeah, we'll take it from there. So I'll see you guys again hopefully tomorrow. I am here for a conference, so it gets busy. We'll see, but thanks for those who are watching the playback, and we'll see you in the next one. Take care.